Hello, my name is Sara Maines, and I'm the director of the Liver Cancers Department at Global Liver Institute. We are so glad that you have joined us today. Global Liver Institute is the world's largest liver patient organization, and we bring together over 200 organizations across our councils, campaigns, and events to continue to advance liver health as public health, both preventing liver disease and scaling optimal approaches to improving the lives of individuals and families impacted by liver disease and liver cancers. You are joining us on behalf of GLI's October is for Liver campaign, the first and only global campaign that's dedicated to public awareness, policy, and clinical practice needs to prevent and manage liver cancer, while educating and empowering those living with and impacted by liver cancer. We are so glad that you're here. The 2023 October is for Livers campaign will not only push boundaries in equity, advocacy, and innovation by connecting diverse communities all over the world to collectively tackle liver cancers. The whole is truly greater than the sum of its parts, and this couldn't be more accurate to describe GLI's value of driving a better future in liver health through a global approach. Today's conversation will be led and moderated by the fabulous Dr. Suzanne Warner, hepatobiliary and pancreas surgeon at the Mayo Clinic. We will be exploring various symptoms of liver and liver transplant surgery, ranging from access to treatment and recovery. Dr. Warner, thanks so much for being here and moderating today's discussion.
Thank you so much, Sarah, for that kind introduction, and thank you so much for the invitation. I am absolutely thrilled to be here with two of my truly very favorite women in this country, who are some of my favorite HPB heroines to learn from and speak with. So I'm joined today by Dr. Alice Way, who is the co-director of surgical initiatives and at the David M. Rubenstein Center for Pancreas Cancer Research at Memorial Sloan Kettering, and also an associate professor of surgery at Weill Cornell School of Medicine. She is an amazing champion for quality and also for sensical use of resources, and also is a phenomenal surgeon, both minimally invasive and open. And I am also joined by Dr. Juliet Emamaullee, who is an associate professor of surgery and the associate director for the Department of Surgery's Division of Clinical Research at Keck School of Medicine at University of Southern California. She's also the research director for the Division of Abdominal Organ Transplantation and holds a dual appointment at the Children's Hospital of Los Angeles. Both of them are phenomenal champions in their own right for all things good, and I'm so excited to have a conversation today. So Dr. Way, I'll ask you to kick off this conversation. Is it possible for you to define for us and provide an overview of what it means to be a hepatobiliary surgeon and what it is to have hepatobiliary surgery?
You know, I think it can be a very confusing term for patients, because that term hepatobiliary surgery or hepatopancreatibiliary surgery is a lot of letters, and not everyone knows what that is. So really, these are the hepato is just a Latin word for liver. Biliary is a Latin word for bile duct, and pancreatic is a Latin word for pancreas. So that means we really specialize in taking care of patients with diseases that involve the liver, the pancreas, or the bile duct system. And we are surgeons, so we really treat surgical diseases of that. And that can be growths in the area, blockages in the area, and that we can really guide treatment with, as the surgeons or with the medical teams, for patients with diseases that involve the liver or the areas that are adjacent to the liver, which are the bile duct system and the pancreas.
Thanks so much. How can you elaborate for us? How would a patient come to meet a hepatobiliary surgeon usually?
So often they are referred by their own doctor. So they develop a problem that involves their liver or their bile duct system. In particular, they might have symptoms related to the way their liver functions or their bile duct system functions, and they can have blood test abnormalities or symptoms or both, and imaging tests which show that there are some changes, and then they come to see us to help for us to help determine what the diagnosis is and be involved in the treatment.
Thank you so much. Now, Dr. Emamaullee, you perform transplants on both adults and children. Can you, while your patient populations are dramatically different, one commonality would, of course, be anxiety or fear from patients and their families that come with such an extensive procedure. What can patients and their families expect as they prepare to face a liver transplant? And how would they meet you, a transplant surgeon? And then lastly, what makes a patient better suited for a transplant as opposed to a liver resection? So just a few softball questions there.
So I think that for most of the patients that we transplant, they've been struggling with their liver disease for some period of time when they come to the ultimate option of having their entire liver replaced through the process of transplantation. So by the time they meet the transplant surgeon, they've been kind of mentally preparing for it for some period of time, and their doctors have been talking to them about it being on the horizon, depending on their underlying disease process. And even for the smallest of children, their families have been somewhat prepared, whether they have something like biliary atresia or a cancer like hepatoblastoma. There's always been in the background that transplant might be the ultimate answer for cure. So part of the process of undergoing liver transplant is meeting a really big multidisciplinary team that includes doctors, surgeons, nutritionists, social workers, nurse coordinators, and really it's designed to sort of embrace the patient and their family through a really medically complicated and often socially complicated process of transplantation. And so when it comes to whether or not a patient should get resection versus transplant, I think most of us would always prefer that we could not do a transplant for patients because it comes with the risk of a huge operation as well as lifelong immunosuppression and technical complications like bile duct narrowing. And so we generally will move forward with transplant if we feel like we can't safely do a resection for a cancer, for example, because of the extent of disease or because of the amount of chronic changes in the entire liver such that it couldn't remove a portion of it. Or for other anatomical reasons, transplant becomes an option. And the subset of patients that we struggle with these issues you asked me about the most is acute liver failure, when somebody presents with, really severe and rapid onset liver failure, often includes mental status changes. So their families have to make a lot of the decisions for them. And they may kind of come through transplant on the other side and understand the gravity of what's happened to save their life after it's already happened.
Thanks so much for that. That was super thorough. So, Dr. Way, amidst an era of significant advancements, minimally invasive surgery, which is something that you are very wonderful at and pushing forward, are sort of reshaping the trajectory of liver surgery. Could you give us some background on these types of resections, on minimally invasive liver resections, and who would be eligible for these? And how they benefit us. Yeah. Sorry.
So the idea of minimally invasive surgery, so traditional minimally invasive is called laparoscopy. So straight sticks, cameras inside to take a look with straight instruments. The more modern way of doing minimally invasive surgery is robotic assisted approach, where really, in addition to having wristed instruments, the real revolution is, in addition to small incisions, is actually a computer assisted approach to surgery. So, and it is very clear that in the future, much of surgery will be done minimally invasively, or more accurately with a computer-assisted approach where the computer helps us do things that we can't do with the naked eye. In terms of liver surgery specifically, what we know about minimally invasive surgery is that the recovery may be faster, that patients have smaller incisions, there's less physiologic disruption from the operation itself. And in particular for patients with liver disease, where they may have underlying liver disease and a tumor that requires surgery, that the minimally invasive approach allows patients to recover faster and it's less stressful on their liver. So patients with even modest liver disease where traditional open liver surgery was not possible, they may be able to have minimally invasive approach despite having some degree of liver dysfunction. In terms of who is eligible for minimally invasive approach, not every single patient will be. They can be determined by factors related to where the growth is, what the extent of the operation required is, and whether they have any previous restrictions or previous surgery that would make minimally invasive approach either not feasible or not the right thing for them. So in a modern mixed liver practice, approximately 30% of patients are able to have a minimally invasive approach. In the future, that may grow to 30 to 50, but it will never be 100%, but it should also not be zero. So we tend to recommend minimally invasive surgery whenever feasible, when it's the right thing for the patient. But ultimately, every patient should have a tailored operation for what they need for their situation.
Thanks so much for that. Dr. Emamaullee, just briefly, minimally invasive transplantation for liver, specifically putting a liver in, I don't envision happening in the near future, but can you speak briefly as to kind of minimally invasive techniques in liver transplant and how they come up and how they get employed?
So the first robotically implanted living donor liver transplant was done in India last year, and the first deceased donor robotically assisted deceased donor transplant was done at WashU a few months ago.
Look at me, standing corrected. Congratulations, colleague.
Yeah, so there's a lot of effort in this space, particularly for the donor operation for living donor liver transplant, because that enables these really altruistic individuals who are donating up to 60% of their own liver to somebody they care about or potentially a stranger. Enabling them to recover quickly from surgery and resume their normal life is enhanced by minimally invasive techniques. Although the backbone of all of that is safety, particularly with living donation, is, we always want to do what we can for patients that would otherwise never be undergoing surgery. So that's really been where the push has been, is in the donor side for living donation.
And I'd love to open the floor to both of you. Obviously, we all desire minimally invasive surgery. Both as surgeons, we want to be able to do it, and patients, they want to be able to receive it. What sorts of questions, as we're as a field going through our learning curve, I think sometimes patients may not fully understand the experience of the surgeon that they are being offered minimally invasive surgery by. What questions would you have if you were walking your family member through this process? Dr. Way for a cancer resection and Dr. Emamaullee for a transplant of the surgeon. What sorts of questions would you ask of a surgery team offering minimally invasive surgery or advocating for minimally invasive surgery?
Well, I would say that everybody is interested now in having better surgery, better quality surgery, and recovering more quickly. It's really, and so that the idea of a minimally invasive approach is very attractive for patients because they like the idea and it makes common sense for the recovery to be better. I think what's important to ask for minimally invasive surgery, but also any surgery, is that you want to make sure that your surgeon has the right expertise to do the operation that they have planned for you. And they're really recommending the surgery for you because they think it's the best option for you, not just what's available to them at the moment, right? So you want to make sure that your surgeon has expertise in the area. The easiest way to measure expertise is actually volume, how many cases they do, either how many cases they've done, how many cases their unit does, because in addition to just having the operation, you want to make sure that you have the right team experience to recover from surgery safely. Specifically in terms of minimally invasive approach, you want to see how many operations, similar operations that they've done specifically from a minimally invasive approach, and whether or not they feel comfortable with it for them, right? So it's hard to quantitate the exact number, but basically for patients, what they should know is that experience counts. And that experience is experience with the same case, similar cases, and that their team, not just the surgeon, but the nurses, the anesthetists, the other surgeons, the hospital, has experience with the same kind of surgery.
Dr. Emamaullee, anything to add as the transplanters are on the forefront of this?
What I would say is that for patients and their families to kind of temper their enthusiasm for minimally invasive approaches with the need for safety, so that if for whatever reason, we start off with one intention and we change our plan for whatever reason during that case, it doesn't signify an incompetency or anything lesser or more. It's just in that situation, the surgeon is doing whatever is safe if they have to change to a traditional open operation. And so to not have too much anxiety about that and sort of temper their expectations in that space, which I think that sometimes people get so fixated on one sort of process when they're trying to go through the uncertainty of a big operation that it can kind of go either way, as we all know as surgeons.
Thanks so much for that. I'd like to pivot a little bit away from technique and into kind of some of the more human aspects of how we care for people. So both of you serve in two of the most racially and ethnically diverse cities in the country, with Dr. Emamaullee in Los Angeles, Dr. Way in New York City. And we know that people of color and marginalized communities disproportionately suffer from liver disease. In considering the geographic areas that you serve, what similar statistics or what statistics revealing these inequities have you seen in your practice? And what do you think surgeons can do in their everyday practice to try and even some of these inequities or alleviate them in some way?
I mean, I can just say in terms of liver disease, particular hepatocellular carcinoma, we know it's actually a very, very common cancer worldwide. In North America, it's less common because of our geographic makeup, but also our ethnic makeup of the risk factors for liver disease and cirrhosis, which include, of course, the viral hepatitis. They include alcohol exposure, and of course, in non-alcoholic fatty liver disease, which has actually now been renamed metabolic associated steatotic liver disease. So I think one of the best ways that we can be mindful of it is, first of all, just recognize that patients may have these risk factors, and that even in patients who are not known to have liver disease, sort of think about liver disease in all the patients that we treat for any condition. For patients specifically with treatable diseases like hepatitis B, I think it's actually very important to screen patients for this. For patients with hepatitis B, to counsel their families, to be screened, to be vaccinated, so that we can prevent and reduce from a public health. That's probably the best initiative that we can do, is make sure that their families are screened and treated whenever possible. I do feel that it is under recognized in some jurisdictions, and it's hard actually to identify patients with liver disease, as we all know, and sometimes they're identified later than they should be. So prevention being part of the public health advocacy, making sure that people are screened, treated, and importantly that their families are screened and treated, made aware, can make a big difference.
Dr. Emamaullee?
So when I think about in the context of liver transplantation, we know that the best results are obtained when we have living donor liver transplantation. And there's a lot of inequity in access to living donor liver transplantation. Not every patient is at a center that offers that. We're the only center in Southern California that offers that procedure. And there's patients that might be on public health insurance like Medicaid in other states that have no living donor programs, and they can't leave their state for their transplant care. And so they have zero access. Even among the patients who do have access, if they are of an ethnic background that has higher incidence of liver disease, it can be harder for them to find living donors because their family member may have a little bit of a fatty liver, for example. And so that can just create a further inequity for them. And then the last thing is that we know that there's some financial toxicity with going through transplant, and especially living donor liver transplant, both for donors and recipients. And we don't have enough financial support to kind of help with the time off. So in the state of California, you're guaranteed 4 weeks of unpaid leave if you become a living donor, either for kidney or for liver. But that doesn't mean that you're going to be able to survive without that income. If you have children at home and the wife wants to donate to the husband, for example, who's going to take care of them both recovering from surgery, who's going to help out with the children, how are they going to pay their bills? There's lots of doctor's appointments. So as a community, as an American physician community, we have to figure out how to erase these inequities so that we can get the best results for these patients.
I want to zoom in a little bit on the importance of screening and the quality of screening. I think, more and more as we see a lot of private equity, healthcare companies, we have a focus on the bottom line over the quality. And so one institution's, liver ultrasound or even liver MRI might not be quite as accurate as another. So when we're teaching our patients and their families to advocate for themselves and for one another, what priorities would you have them set as we seek out screening programs for patients and their families who might be at high risk for liver cancer? I'll ask Dr. Way to go first, since we've been going in that order.
That's a very big question. It's tough, I would say. I do think it's quality, of course, is the most important, and the mix of of finance and quality is very challenging. The idea of value in surgery or value in healthcare, where the quality and the cost are well balanced, is important. So High quality can also be the cheapest, right? It can be the best. Identifying people with screening so the disease is early, can be treatable, can be curable, will lead to the best outcomes. And I think making sure that physician leaders are part of the discussion with insurance companies, with private equity in the leadership of healthcare can really help translate what we do in terms of quality of care to the bottom line. Because at some level, we would expect that they can be aligned in terms of value. Right? Teaching patients about how to look for value is very challenging. I think it's important. Of course, they should always think about quality and seek quality. And I think one of the things is that there can be very cost-effective and high-quality programs. Part of it is to find them, and part of it is to try to be involved in them and to advocate for them. So I do think it's a real challenge, but I think physician leaderships, physicians being involved in the delivery of healthcare, direct delivery of healthcare, and all of us working for high quality care, also high value care, it can help the healthcare system deliver the best kind of treatment, best kind of quality for all patients.
Yep, I'll get it to you. Yeah.
So my perspective on this, if I think about it, as somebody kind of came up from with a limited access to healthcare and to doctors and seeing my family go through these things, I really believe in the primary care model. And I think that it's really important for patients to have a good, solid relationship with a primary care physician who kind of manages all the aspects of their healthcare and can help them with all the surveillance, whether it's for their liver, ruling out breast cancer, colon cancer, all the things we worry about in our patients, and having that be kind of their home base for their healthcare, so that when you see them, you can say, hey doc, how's my liver doing? Should we be testing for that this year? And they kind of work with the specialists like all of us and say, yeah, I just talked to Dr. Warner, a few months ago, and we're going to get you a scan next year. I really think that it's hard for patients to navigate the healthcare system, and having somebody kind of serve as the pilot in the primary care setting, whether it's for a child or an adult, is critical for continuity of care.
Thank you guys so much for that. In the few minutes that we have left, I would love to just touch briefly on what it feels like to be a surgeon, and what messages you might convey to those interested in pursuing this as a career. Both of you, I know, have been involved in initiatives to make our profession look more like the populations we treat, I should say. So I would love to hear from you. Either something that you feel like we can all be doing to help garner the next generation, or a message you would give to any young people considering a career in surgery.
I mean, I would tell people that if they're interested in surgery and taking care of people, that surgery is an incredibly satisfying career. For most of us, like the three of us, I think it's a real calling. There is no greater pleasure than helping patients be better and feel better and contributing to the quality of life. Is it a tough job? I think it's a tough job. I think most jobs actually are tough, but I think that it's just immensely satisfying, and it's immensely rewarding.
For me, it's such a privilege to be involved with patients and their families during such an intimate and stressful period when they're dealing with end-stage, organ failure, especially in children. And seeing them in such a sick state, and the very measurable aspect of performing a transplant and having the liver or the kidney start working right away and have the patient recover and go on and live their life. When you run into them a year or two later and they're unrecognizable because their liver disease has resolved is always is really fun and some of the best part of our job. So for me, even though that they say in transplant the highs are high and the lows are low, most of it is high, and I wouldn't change it.
Thank you guys so much. I would echo all of that and just add that it's such a privilege to have such an intense patient-doctor relationship that also tends to have an endpoint, right? They get better, they leave the hospital, they recover, and our success is that they're living their lives and that they don't need to see us again, though I do enjoy having them come back year after year to see them and celebrate with them the added years on their life. Again, thank you so much. What a wonderful conversation. Thank you both for your support and commitment to our patients suffering from liver cancer, and also to our community of surgeons and HPB heroines that I'm so thrilled and proud to be a part of. I pinch myself every time I have conversations like this, webinars like this with leaders in the field, that I get to even share a screen with anybody. But thank you so much for your time today and for your work. Appreciate both of you.
And Dr. Warner, thank you. You took the words out of my mouth. I want this conversation to be another 2 hours long, please, because I can feel the passion. I see your level of acumen and precision to this field, and also what that brings to the patients and families that you help with. The fact that you all mentioned, cancer-related financial toxicity. You spoke about the importance of patient and family advocacy, about navigating the health system and what the primary care provider and that, navigation and responsibility looks like. You touched on so many things, and I think that it's important, and I hope that the greater audience that's viewing this today sees how incredible, there's the multidisciplinary team component of this. You can feel it. I can see how you lead and take responsibility in this space. And GLI, myself personally, we are honored to collaborate with you, to the leaders and the female leaders in this case who are helping our liver community. I'm so proud of the work that the three of you are doing and how that changes the way patients and their health and long-term care are handled. So thank you, because it is a true privilege to work alongside all three of you. We thank you for your continued commitment to our community, and I appreciate your support of our October is for Livers campaign. I want to make sure that the audience that's viewing today and moving forward on this broadcast knows that if you need more information about liver health, about liver cancers, liver disease, please reach out to GLI. Visit our website at www.globalliver.org. Also come to livercentral.org. We have a plethora of resources and a variety of information and a variety of languages, and really want to be a hub for liver cancers research and resources. Thank you again, Dr. Warner, Dr. Emamaullee, Dr. Wei. We appreciate your time and dedication.
Thanks again.
Thank you, everyone. You're welcome. Bye-bye.
Bye-bye.
Bye-bye.